No, that's not his actual name.
No,
His name is Jasmine.
really? Run for me quick one. Hey guys, I think we might do the last one. Before we do that, just like tomorrow is the last day for the mentorship program. This I'd highly recommend all of you if you haven't already. And just
Wonderful. Hi everyone. So today I'm talking to you about drugs. My name is Jasmine, second year. Dog is named Jasmine, and that's the only really exciting thing about me. Yeah. Okay, so first up, pharmacology is quite dry, it's quite boring, it's lots of memorization, but it's also quite high yields compared to a lot of the other topics. So definitely worth being on top of when you're heading into exams and things like that. And it does help with a lot of the physiology as well. Cool. So just to begin with and to guide some of the learning that we'll do. Sorry guys. So Richard is a 58-year-old diabetic who comes to see you due to a flare-up of his rheumatoid arthritis. So firstly, he says that his old GP was worried about the impact of his ongoing alcohol consumption on his ability to take medications for his chronic illness. So first up, we're going to look at pharmacokinetics. So a bit of a throwback to the very beginning of the semester. Now with the content, there's a lot of slides you might have seen in the pre-slides because there's a lot of pharmacology covered. We're going to rush through a lot of the content. If you have any questions or want me to cover something in more detail, please just throw your hand up and let me know, or just shout out. I really don't mind. But apart from that, we'll just kick off. So these are the objectives from your lectures. And essentially pharmacokinetics is what the body does to the drug. So you're looking at the different phases. So can anyone tell me what the pharmaceutical phase involves? Just shout it out. Yeah. So A, it's literally like the capsule dissolving in your body, things like that. Nothing too exciting. So pharmacokinetics, we have liberation or the pharmaceutical phase, which we just looked at, absorption, distribution, metabolism, and excretion. So absorption, you have bioavailability. So that's the amount that the oral administered drug, how much of that reaches your systemic circulation. So that's after it passes first pass metabolism in the liver and that kind of thing. So bioequivalence, however, is when the two formulations of the same drug attain similar concentrations. So that's only important like if you're looking at generic drugs compared to the ones that already exist. So orally, you have to consider things like your gastric content, so whether you're eating it before a meal, after a meal, that kind of thing, intestinal motility, blood flow, and stomach acidity. So the stomach is lipid-soluble and weak acid. So aspirin does well in the stomach because it's weak acid and lipid-soluble. And small intestines is the primary site of absorption for drugs. But you would have noticed that you can give drugs other ways, so parenteral, so intravascular, intramuscular, and subcutaneous. So that doesn't rely on first pass metabolism. So you can see in the graphs and things that you would have looked at, they act a lot faster. Yeah, that's basically it. So everyone's favorite part of pharmacokinetics is the volume of distribution, which still is confusing. So that's the volume that would contain a certain total body content of the drug at a concentration equal to the measurable plasma concentration. So you know that when you take a drug, it goes everywhere. It's not just in your blood, but volume of distribution looks at if all of the drug was in plasma, how much plasma would you need? So that's the volume of distribution, how much plasma you would need to achieve that concentration that the drug is at in plasma at the moment. So basically what you need to know is that higher volume of distribution means that a lot of it's in the tissue. So that means you need a lot of plasma to have that concentration. And if you have a low volume of distribution, it means that most of it's staying in the blood. So you need less blood to achieve that concentration. So that's impacted by things like the size of the molecule, lipophilicity, the degree of ionization, and plasma protein binding. And the volume of distribution is important because it tells us things like dosing and elimination. So phases of drug metabolism, you've probably looked at this as well. There's two phases of the reactions. So the first one is catabolic, so it's breaking it up. So things like oxidation, reduction, hydrolysis, and they often introduce a reactive group. So this is called functionalization. So this increases polarity, it makes it water soluble, so helps with getting it out of the body. But it can cause things like toxic or active metabolites, and that's where we see some of the adverse reactions with things such as paracetamol. And the next one is phase 2, so that's anabolic, which is synthetic, and that involves conjugation. So usually that causes an inactive product, and it may insert some of these things, probably not too important to know exactly, but yes. And then there's the pharmacokinetic triangle. I'd recommend learning this if you learn anything out of pharmacokinetics. They tend to like ask, okay, if I increase the rate of excretion, what will happen to the clearance? Or if I increase the amount of drug in the body, what will need to compensate for that and that kind of thing. So I'm not going to run through it simply because it's something you just need to sit down and look at the formula and look at the triangle and figure it out. But definitely recommend being on top of that one. And just like if you go into your exam, same thing with the brachial plexus, just write it down. And that way you can refer to it later. Cool. So elimination, you probably know the half-life is the amount of time that it takes for the concentration to reduce by 50%. So that relies on the volume of distribution and clearance, as you can see in the formula here. And that determines how long the drug works and how long it takes to reach the steady state. So steady state is achieved in about 4 to 5 half-lives. And the time to eliminate the drug is also 4 to 5. So yeah. First order metabolism, that's the exponential one. So the rate of elimination is proportional to the plasma concentration. So the more drug you take, the faster it gets eliminated. And that's in comparison to zero order, which the rate is constant no matter how much drug you take. And that's really important with things like ethanol, because the more alcohol you have, it doesn't necessarily mean your body is going to eliminate it any faster, which is why you're at increased risk of overdose and things like that. Yeah. Okay, so which would indicate high tissue sequestration? Anyone want to shout it out? See? Yeah, amazing. I'm sorry I don't have chocolate because I'm really poor, but I really appreciate your participation. So which factor most directly influences the rate of elimination of drug X? Anyone want to shout out an answer or anything? Okay. Yeah, so it's clearance. And you can see that in the triangle. The rate of elimination is here, and it has clearance and plasma concentration. So those are the direct impacts. All the other ones are kind of indirectly impacting the rate of elimination. Cool. So which of the following is false, regarding the therapeutic index? So that's just that narrow window where it kind of helps. Anyone want to shout it out? Yeah, so I was hearing C. So the higher the therapeutic index, the better it is. Cool. Yeah? D. It is divides the dose. That doesn't make sense. Yeah, so it's the dose that produces toxicity in 50% of the population.
Hold up. Oh, I love Jasmine Elliot. I'm really sad I didn't get to go to hers.
What?
Oh, she's internal.
Yeah, that's what I said.
Someone's got their mic on Zoom. So. Hope you're having a great day at home. Yeah, so it's basically because it's a proportion of like what's toxic and what's not toxic, and because it's like 50% of the population, that's just how they calculate it in terms of, yeah, it's not really important to know. But I guess with questions like these and questions in the exam in general, don't worry if you don't know a particular answer. They throw in things that are tricky or haven't taught you, simply because they know that you will know that like C is wrong, if that makes sense. So in the exam, there'll always be like random answers of things that you don't like, that you haven't covered. Just rely on the answers that you have covered and see if they're true or false, and it should help. Cool. So as a part of your thorough medical history, you also asked Richard what medication he's taking for his rheumatoid arthritis. So we move on to DMARDs. So there's our 5 hallmarks of inflammation, so dolor, color, rubor, tumor, and functionally so a bit of Latin, I guess. Rheumatoid arthritis, there's too many white blood cells. Gout, there's too much uric acid. White blood cells cause damage to your joints, and gout causes pain because it's basically like crystals in your joints, which is not fun. So he is taking azathioprine, I can't even say drug names, to treat his RA. This works fine. E? Yeah, so it is E. And you can see the different actions of the different drugs there. So synthesis of folate is methotrexate. Transpeptidase is preventing cell wall cross-linking. That's things like penicillin. Uric acid excretion is probenecid, and uric acid production is allopurinol. So Rich is white, scarlet, suffers from gout, and he wants to know why they don't take the same meds, because a lot of their symptoms are the same. And also Richard can't have too many conditions because that would be sad. So which of the following drugs is used in the treatment of gout and has its primary effect in the reduction of uric acid synthesis? Anyone want to throw out an answer? D? Yeah, so allopurinol helps in terms of production. And yeah, this is a pretty handy diagram because it has the 2 main drugs for gout there. Cool, so management of gout, there's 3 main drugs. Allopurinol, so chronic gout. This is something that people will take if they have gout kind of regularly. So it's a competitive inhibitor of xanthine oxidase, as you can see here. And that decreases the conversion of hypoxanthine and xanthine to urate. Not really that important to know the specific compound names, but know that it prevents production of uric acid. So adverse effects, those things, indications, obviously gout is the main one to know. Colchicine is acute gout, so it inhibits the microtubule depolymerization and impairs neutrophil chemotaxis. They're not really sure of the mechanism of action of colchicine, so not really important to know. But yeah, it does cause some GI symptoms. And probenecid, I think that's how to, I don't really know anyone who knows how to say that drug name. But the mechanism of action is it inhibits resorption, so it helps excrete uric acid. The issue is that it can precipitate calculi that already exist. Okay, so which is useful in an acute gout attack? Colchicine. Yeah, so D. So basically, to remember that it's acute, it has lots of C's in it, kind of looks like Pac-Man. It's eating up the uric acid crystals that are formed, so acute, kind of short term. That's how I remember it. Don't know if that'll help you. So Richard says that his RA is becoming more painful and wants to explore different types of pain medication he might be able to take. So here we move on to pain. Pain is painful, and there's lots of drugs that you can take to reverse it. So this is something I drew last year in my 2nd semester, and it basically has all of the drug classes and types that you cover. Feel free to look at it. Feel free to not look at it either. It can be really useful to just do it yourself as well, rather than try and follow on. Cool, so these are the objectives from your lectures. And yeah, so basically what is pain? You've covered this a little bit in terms of like the A delta fibers, C fibers, that kind of thing. And whether they're myelinated or not, that's not really a pharmacology thing, but worth knowing in terms of phys. So overview. So there's a number of different parts in the pain pathway that we can interrupt with in terms of drugs. So transduction, we have our anti-inflammatories, so NSAIDs and steroids, local anesthetics as well, so with wound infiltration. Then moving up, we have transmission, so moving from the site to the spinal cord, and things like local anesthetics work there, and opioids, perception, CBT, nice hep throwback, and descending modulation is also opioids. So opioids work at a few different levels, and that's important to know in terms of the effects that they can cause. So this is the analgesic ladder. I'm not sure if anyone saw like the Transformer ladder ad on like morning TV, but yeah, so know this one. Basically, it makes sense. You start with the simple things that you can get over the counter. You work up to a weak opioid. You work up to a strong opioid, and step 4 is probably dropping out of medicine. So yeah, that's how you deal with pain. So we'll break it down into small steps. So the first one, NSAIDs. Again, this is a really good diagram. Like diagrams can really help with pharmacology, just in terms of seeing how everything works on a bigger picture. So we'll start with the NSAIDs. So this is a lot of detail. It's really pretty though, and the main things you need to know are where the glucocorticoids, NSAIDs, and COX-2 selective inhibitors work. And these things will become more useful as you move into later years. Okay, so TLDR, so quick summary of all the different ones you should know. Paracetamol, so our simple analgesic is centrally active. Ibuprofen is non-selective and it's more peripheral. Aspirin, we know that it inhibits COX-1 at low doses and it's non-selective at high doses. So we take it at high doses for pain relief and low doses for things like clotting. And meloxicam and celecoxib are selective. Celecoxib literally says it in its name. And yeah, so your adverse effects you see quite often for most of them, things like gastric ulcers, renal ischemia, GI issues, that kind of thing. Cool, so paracetamol, this is a bit more detail. I'm not going to go through it really. Know that there is an interaction in terms of its pharmacokinetics. So it can cause hepatotoxicity if you're taking lots, because there's a particular enzyme that is a rate limiting step in its elimination, and if you take lots, then you run out of the enzyme and it's bad for you. Cool, and there's no anti-inflammatory action either. So it's basically analgesic, antipyretic, and more centrally active. Ibuprofen is more peripheral, and that's where you see your things like your renal failure and things like that, your nausea, vomiting, that kind of thing as adverse effects. Yeah. Aspirin, so as I said, it's dose dependent. So low doses don't really have any anti-inflammatory effects. Higher doses start to have anti-inflammatory effects. And that's about it. So with aspirin, it can cause salicylism, salicylism. And it basically is bad, again, causes things like headache, confusion, and you would have covered this in your well. You use sodium activated chalk and line diuresis. Yeah, and it cause gas. An allergy or NSAID intolerance, don't give them aspirin. Cool. So new generation NSAIDs are designed to inhibit, just shout it out, it's a pretty easy question. B? Yeah. Yeah, so it's good for drugs to be selective because COX-1 is useful. It's good for normal physiological function, so gastric mucus production, enhancing kidney function, normal platelet function, things like that. So inhibiting those sorts of things are bad, and that's why we have our selective ones. Obviously, they're better for like long-term use, that kind of thing. And you decrease your inflammation without decreasing your normal function. So this is meloxicam. Note that celecoxib has impacts cardiovascularly, so they increase your risk of myocardial infarction, so don't give it to people with like heart failure, angina, or peripheral arterial disease. Yeah. So an adjuvant in our ladder is anti-inflammatory agents such as steroids. So can anyone say what the enzyme that they act upon is? Yeah, so I had a couple of Ds. It's phospholipase A2. So basically they bind to a cytosolic receptor, which means that they have to go into the cell. A lot of drugs work on the outside and then go through a signaling pathway. Important to know the glucocorticoids have to go inside, and that's why they need to be lipophilic. And yeah, so essentially increase transcription of anti-inflammatories and decrease transcription of inflammatories. So that decreases your things like vasodilation, decreases leukocytes, decreases fibroblasts, so on and so forth. Basically, you get less inflammation because you're having less of these proteins generated. So notably, there's mineralocorticoids, which are water balanced, so things like aldosterone, those are produced in the adrenals, and glucocorticoids are involved in like the stress response, so cortisol is quite normal to have in the body, and anti-inflammatory above those normal levels that you see in the body. So these are the core ones. Obviously, one of the adverse effects that you see with most of them is Cushing's, and things like acne, mood swings, constipation, that kind of thing. And yeah, the indications are there as well. So those are the ones that have been listed in ePharmacology. And you'll learn a bit more about fluticasone next year when you do rest. Cool. So prolonged glucocorticoid excess can lead to okay. So anyone have an answer for me? Okay. So just in the interest of time, it's C. So basically the issue with the first one is that it says hypotension and it causes hypertension, which I know a few people were tossing up between A and C. Cool. So Cushing's and Addison's, so they're both can be caused by long-term glucocorticoids, because Addison's is when you say take prednisolone for a long period of time and then stop taking it, your kidneys can't really produce it as well, your adrenals, sorry. And Cushing's is when you're just taking prednisolone for a long time. So you get these sorts of symptoms. And yeah, you'll learn a bit more about it when you go into endocrine. But yeah, there's basically this axis here and it's negative feedback. So if you take cortisols for a long period of time, then it means that your pituitary is producing less ACTH and your adrenal gland becomes unable to make cortisol really. So the next one is central analgesics, so looking at your opioids, and they act at different areas, as you can see in this diagram. So yeah, does anyone know the analgesic effects of morphine are? Anyone want to shout it out? E? Yeah, so it's E. This is tricky because you're inhibiting pain, but you're activating the mu receptors. So definitely something that a lot of people get tricked up on, and important to remember that it's activating the mu opioid receptors in the brain and the spinal cord. Yeah, so the general information is that it acts on the mu receptors, also delta and kappa, but mainly the mu ones, and they prevent calcium entry into the presynaptic cleft, which means that you're not releasing the neurotransmitter. So you would have done synapses and things recently, and that prevents the slow, dull pain from C fibers peripherally. And they modulate the pain response as well, so in terms of descending inhibition, and that helps even further in reducing the amount of pain that you see. And it says basically, so the periaqueductal gray is the particular area where the mu receptors are in the descending pathway that they work on. Cool. So these are, again, the main opioids to know, the mechanism of action, indication, and adverse effects. I'm not going to go into them in detail. Just know naloxone is a competitive antagonist, so the reverse. You're seeing agonists of mu receptors, but naloxone is an antagonist, and it's used to treat overdose. And that can basically cause your withdrawal syndrome because it's, removing the opioids that already exist. And methadone can be used as a substitution without those adverse effects for people who are looking to quit. Others, so pethidine and loperamide. Loperamide is important because it's poorly absorbed in the GIT, so most of its effects are concentrated there, which means that it's used for diarrhea and things like that. Cool. Okay, so moving on to local anesthetics. These are the objectives, and this is general information on local anesthetics. So mechanism of action is on the sodium channels. The important thing to know is that they're the voltage dependent ones and they're intracellularly. So basically with local anesthetics as well, they depend on getting into the cell to have their action. So that impacts the type of molecule that they have to be. Important things to know for general anesthetics are the amides versus the esters. Amides have an I in the name before the cane because there's an I in amide. So things like lignocaine. Esters don't have an I in the name. And things like methocaine are esters. So important to know the difference between the two. You don't have to know the specific drugs as such, but knowing what class they're in helps you in terms of how quickly they're broken down. So amides last a bit longer because they're broken down in the liver, whereas esters have a much shorter half-life because they're broken down in the plasma. So they don't have to go anywhere to be broken down. Both of them are renally excreted, so you can have toxicity with local anesthetics, which causes things like drowsiness, that kind of thing, essentially when the local anesthetic makes its way around the body and causes its effects elsewhere. Cool. So again, these are different things that you would have explored during your lecture in terms of how they're impacted. So lipid solubility and potency, that's their ability to get into the cell. More lipophilic, the more potent. So the shorter amount of time it takes to act. Smaller nerve fibers are easier to get into because they are smaller, and there's also ones with less myelination. So that's why you have your pain, temperature, touch, pressure, loss order. And ionization and things like that also impact it because it's crossing a cell membrane. Use dependent, so when your sodium channels are firing, they can be closed, so basically there's no pain. Opened, pain's being transmitted, and if they're open for a certain period of time, they are inactivated. So essentially local anesthetics work on the open and inactive states, which means that they're not impacting normal sodium channels that are just chilling. And yes, so absorption, you usually give things like a vasoconstrictor to keep it in a certain area and to prolong the effect. Cool. So can anyone tell me which isn't an amide? Yeah, so literally just the one without the I in it. So ANS, objectives. Sorry, we're speeding through it. We've got a lot of content, I guess, between this and cardio as well. So these are the different areas that are impacted by sympathetic and parasympathetic activity. So not going to run through it, but basically know the general ideas of what parasympathetic activation does and what sympathetic activation does, and what neurotransmitters are important. I think you would have covered this in the neurophysiology lecture as well. And again, mnemonics to help you out. Sludge for PSNS and dumbbells for SNS. Yeah, pretty self-explanatory, just learn them. And can help in terms of the receptors. One heart, so heart's a beta 1, 2 lungs, so beta 2. Cool. And again, just really memorizing type things. So M1, 2, 3, and 4, and 5. Mostly M1 and M1 to 3, kind of good to know. M4, 5 is kind of irrelevant. Same for SNS, so you have your alpha and beta. As I said, 1 heart, so beta 1, 2 lungs, so beta 2. Yeah. So a couple of things for alpha receptors, noradrenaline is the one that acts most, and followed by the other ones. For beta receptors, it's the opposite, and that's why they're alpha and beta. If you wanted to know the difference, and adrenaline is usually beta over alpha, except for in high doses. Cool, so Richard's orthopedic specialist decides to do an arthroscopy. At the end of the surgery, they decide to use neostigmine. So why would they use neostigmine? Does anyone happen to know the answer to this one? It's a bit of a throwback to some of the things you would have learnt last semester. It's quite similar to pyridostigmine. Okay, so it's A. So neostigmine and pyridostigmine are the same class of drug. Basically, when you give a muscle relaxant, it's a competitive non-depolarizing, so it basically blocks the receptors. And then if you introduce neostigmine, it prevents acetylcholinesterase, which means you have more ACH bombarding the receptors, which knocks off the competitors. And yeah, that basically allows you to breathe again. And what effects would you see if only neostigmine were given? So if you just gave someone neostigmine, what would you see happen? So think about its action here. Does anyone have an answer at all? A? Yeah. So it causes muscarinic effects because it promotes the action of ACH. And what sort of drug would you give to counteract these effects? So something that goes against parasympathetics. Sorry? Yeah. So D. So the thing with succinylmethonium and rocuronium is they are nicotinic, whereas the actions that we're looking at are muscarinic. So you want to, sorry? A muscarinic antagonist. Sorry? So neostigmine is an agonist for muscarinics. And when you give it as a reversal of muscle relaxant, you want to decrease like the bradycardia and things like that. So you give a muscarinic antagonist to stop the bradycardia and that kind of thing. Is that?
And how does it help you when you just say the surgery?
Yeah, okay. So this is kind of a bit more in depth than you guys probably need to know. So basically, he's been given a muscle relaxant, which acts on nicotinic receptors. And to reverse that, we give pyridostigmine or neostigmine, which causes muscarinic effects everywhere. So it acts on nicotinic and muscarinic receptors. So even though you're counteracting the nicotinic thing that's happening with the muscle relaxant, you're also having more parasympathetic activity at the muscarinic receptors. And you don't want things like bradycardia and that kind of thing, so you want to reverse those muscarinic effects. So you give a muscarinic antagonist. Yes. Yeah, anesthetics is more complicated than it seems, I think. So yeah, so you're giving atropine, which is a muscarinic antagonist, which produces sympathetic activity. So you use these things for like eye exams and also to reverse the bradycardia and things you see with a muscarinic agonist, yeah? Oh my gosh. Yes. Yeah, probably. Yeah, I was just talking about the effects. Yeah. So as was rightly mentioned, probably best to refer to neostigmine as a cholinesterase inhibitor or an anticholinesterase. Cool. So now we move on to cardiac. Does anyone have any questions about anything that we've covered so far? I know it's been a bit of a whirlwind. Okay. So the next is cardiac drugs. There's lots of different conditions. Basically, these are the goals of treatment for each of them. So hypertension, you want to be reducing your water volume and total body water, reduce total peripheral resistance. Angina, you want to increase your cardiac output and blood flow to the coronary arteries and decrease the cardiac oxygen demand. Heart failure means your output is not enough for the demand, so you want to increase your cardiac output, reduce your total body fluid so there's less resistance and prevent tachycardia. And arrhythmias, you want to decrease your conductivity and increase contractility. And there's a basic summary of all the drugs that are on ePharmacology on the left. Cool. So hypertension. You want to reduce your blood volume and total body water, and you want to reduce your total peripheral resistance. So then we have the A, B, C, and D of hypertension treatment. So angiotensin converting enzyme inhibitors or angiotensin receptor blockers are A, beta receptor blockers are B, calcium channel blockers are C, and diuretics are D. So a bit more detail, you would have looked at the renin-angiotensin aldosterone system. Good to get your head around this one. It's something that will keep coming up in med first and second semester of next year. And yeah, essentially you're looking at renin contributing to the angiotensinogen to angiotensin 1, which causes angiotensin 2, and that's promoted by ACE. So if we're inhibiting ACE here, it means we're getting reduced angiotensin 2, which reduces these impacts. We can also reduce its impact on the receptors as well. So ACE inhibitors, we have things like perindopril. They inhibit the conversion of angiotensin 1 to 2, as I said, and they also inhibit bradykinin breakdown, as you would see. And so we use it in things like hypertension, heart failure, diabetes, that kind of thing. So they reduce water retention, and that helps in terms of maintaining a low blood volume. Obviously, you can get the reverse impact, so hypotension. The cough is an important one to remember. So when you're talking about ARBs versus ACE inhibitors cause that cough with the bradykinin. Yeah, so contraindication, if you're giving potassium-sparing diuretics, you don't want to give ACE inhibitors as well, because then you get hyperkalemia, which is bad. Cool. And ARBs are the angiotensin 1 receptor blocker antagonists, so that decreases peripheral resistance and increases in sodium and water excretion. So again, you still have that hyperkalemia, but you don't have a cough, which is good. Beta blockers, things like atenolol. So going back to, I guess, the sympathetic activities, we want to block those. So beta-1 adrenoreceptor blockers are things like atenolol. So they're cardioselective. They act on the heart adrenoreceptors. That increases your force of contraction and increases your heart rate and decrease sympathetic drive. That should be reduced contraction and heart rate, I believe. Cool. Sorry about that. I'll fix that up for the post slides on the drive. Yeah, so indications, things like angina, hypertension, post-myocardial infarction, arrhythmia, and clinically stable heart failure. Others, propranolol and carvedilol, they're non-selective, so they can act on the lungs and things as well. So you end up with things like bronchoconstriction. So don't give them to people with asthma is one of the big things with these. Okay, calcium channel blockers, so things like rapamil. So the important thing to know with calcium channel blockers is you have the two different types. So the non-hydropyridine are things like verapamil, so they act on the heart, whereas the dihydropyridine act on vascular smooth muscle. So they cause different impacts because of where they act. So the heart ones you want to treat hypertension, angina, atrial fibrillation, and flutter, and the non-heart ones, so they act on the periphery, so you want to use them for things like hypertension and angina. The adverse effects are listed there. So if you have a vasoselective calcium channel blocker, you can get reflex tachycardia, whereas in the other ones you can get bradycardia and that kind of thing. So worth getting your head around the impacts of what would happen if you decreased calcium peripherally versus on the heart as well. Okay, so diuretics. So the D part of the ABCD. So the first one is loop diuretics, which you probably know about, is furosemide. So they act on the loop of Henle, and that means that you have less sodium retention and the water follows. So you get rid of sodium, water follows it, as you would have learnt, and you get urine excretion. The adverse effects, important ones, are hypokalemia. So when you're getting rid of the sodium, you also get rid of potassium. And that's not ideal because of the impacts that potassium can have, dehydration, that kind of thing. Don't give it to people who are taking NSAIDs. That's how you get your renal issues in particular, yeah. And moving on to thiazides. So they inhibit an ACL reabsorption. So the water follows again. So that means you're reabsorbing less sodium chloride and you're reabsorbing less water. And the adverse effects can be summarized by hypergluc, so glycemia, lipidemia, uricemia, and calcemia. Cool. So thiazides are one of the usually like first line ones that they give. Potassium sparing, so these ones don't cause hypokalemia like the other ones do because they save the potassium. So that's good for people with like hyperaldosteronism or heart failure and hepatic ascites, but you probably don't need to know about them. Cool. So now we have nitrates. So glyceryl trinitrate is the proper name. Usually we just know them as nitrates. So they're actually a prodrug, and once you take them, they form nitric oxide, which causes vasodilation. So it's an endothelial dependent action. So you rely on the endothelium being able to react to nitric oxide. So it reduces the wall tension, and that means that you're decreasing your preload, decreasing your afterload, which allows for reduced resistance. Usually you take them sublingual, so if someone's having an angina attack, you can just give them the nitrate sublingually, and it acts really quickly because there's lots of anastomoses under the tongue. So it's used for acute angina treatment, as I mentioned, and prophylaxis as well. So if they're about to go for a run or something, someone might take a nitrate. But adverse effects are things that you get with vasodilation. So you get like a headache, hypotension, bit of tachycardia, flushing, palpitations, that kind of thing. So you wouldn't give it to someone with hypotension already because they would probably faint. And don't give it to someone with Viagra either. So interestingly, and something to remember as well, is you can develop nitrate tolerance. So you need to have like a nitrate-free period. So maybe 8 hours over 24 hours is the one that they usually give as a guideline. Cool. So even more drugs. We have the cardiac action potential. This is important for arrhythmias. I'd recommend, again, just drawing this out, memorizing the diagram, knowing where the classes work. And that way you'll have like a good grasp of your antiarrhythmics. Okay. So going into each one, there's even subclasses, which is fun. So 1A is used for atrial and ventricular arrhythmias. So this is the bottom one here. So it increases the duration of the action potential, which means you're getting less heartbeats. So supraventricular tachycardia, and it increases the effective refractory period. The issue is it impacts the QT interval. So you would have learned about torsades, which is another arrhythmia that you can cause by treating arrhythmias, which is a bit sad. 1B is lidocaine. So it's for acute ventricular arrhythmias, so post-MI. So you can see that it decreases the action potential duration here. And then 1C is supraventricular tachycardias, including atrial fibrillation. So it prolongs the effective refractory period. So it doesn't really affect your Purkinje fibers or anything like that, but it's contraindicated in ischemic heart disease. And it can be pro-arrhythmic too, which is not ideal. Class 2 are your beta blockers. So they decrease the gradient of the sodium funny current, which slows the rhythm of the heart. So if you're getting reduced SA to AV node conduction, it means that you're treating things like supraventricular tachycardia. So that's supraventricular basically means like things above the ventricles, and atrial fibrillation and flutter just by decreasing the gradient. Cool. And class 3 are potassium channel blockers. So those increase the duration of your action potential because you're not getting your repolarization as fast as you usually would, which prevents it from depolarizing again. So increasing your effective refractory period and also increasing your QT interval, again, can cause things like torsades. So it's good for atrial fibrillation, flutter, and ventricular tachycardia because you're slowing down the rate that it has the action potentials. And then there's a few particular ones. So amiodarone is a calcium channel blocker. And yeah, so basically there's a few adverse effects. Mainly the torsades one for for potassium channel blockers, sorry. And then class 4, as we've discussed already, there's calcium channel blockers. So they target the plateau phase, as you can see here. It makes it a bit longer. So that's good for supraventricular tachycardias, atrial fibrillation, and atrial flutter. A lot of them are used for very similar things. So this is not one of the classes, it's kind of its own thing, adenosine. So it hyperpolarizes cardiac conducting tissue, which means that it can't depolarize as fast. So it's used in re-entrant supraventricular tachycardia. Its adverse effect is bronchospasm because the alpha-1 receptors and that kind of thing. Yeah. And digoxin, I don't know. Again, people pronounce it in different ways. Mechanism of action, it inhibits the sodium-potassium ATPase pump, so that increases the amount of intracellular calcium and sodium, which means reduced conduction, increased automaticity, and increased force. So this is good for atrial fibrillation and heart failure. So it's called a positive inotropic effect. And that's to do with like ion channels and things like that. But it's really important to know and be aware of the increased risk of toxicity. So if you have decreased potassium with your diuretics and increased calcium, you can have an increased chance of toxicity. So don't give digoxin with diuretics. Yeah, okay. And moving on to lipid-lowering drugs, because there just weren't enough to learn. So mevalonate synthesis is inhibited by things called statins. So they're the HMG-CoA reductase inhibitors. You can see them here. This is important for hypercholesterolemia. So with the lipid-lowering drugs, it's really just important to know what they're used for. Different lipid-lowering drugs are used for different conditions. So this one's hypercholesterolemia, and that's the statins. They have statin in their name. So HMG-CoA reductase, yeah. And you know it's for hypercholesterolemia because it prevents the production of cholesterol from acetyl-CoA. More is fibrates, so they inhibit pro-LPL, which is here, which means that you get increased triglyceride clearance. So you use it for triglyceridemia. Makes sense. And then there's ezetimibe, which is up here, and it prevents cholesterol absorption. So that's used for mixed hyperlipidemia, so both of the above. Cool. So important things to know with your cardiac drugs is don't combine things which have the same effect. So if they ask you in an exam, they'll usually say, oh, this person's taking this drug for this condition. It's not really working as well as we'd hope. What other drug would you give them? So it's important to kind of know what not to combine. So beta blockers with ACE inhibitors, both of them are inhibiting renin, so don't give them both. Beta blockers with calcium channel blockers both increase contractility. So basically giving two things that cause the same effect increase your chance of adverse effects. So definitely know things not to combine. There's stuff here to talk about like what to combine. But yeah, I definitely recommend learning those. You can kind of think about it and reason it out. But if you're the type of person who memorizes things, which I'm not, it can be useful to have a look at slides like this. Yeah, so TLDR, this is basically a summary of what to do in each of the conditions. Cool, so vasospastic or variant angina is likely to be worsened by does anyone know? Most of the next slides will be questions. So if you guys want to shout out the answer as soon as you know, I can move on and we can get through them. Anyone know? Okay. So it's beta adrenergic receptor blockers. They can cause rebound angina. Do you guys know these? Or? Does anyone have an answer to shout out at all? Or? So it's kind of tricky. The big thing is the fact that he suffers from bronchial asthma, so you wouldn't give something like propranolol. Lidocaine is a, go back to our antiarrhythmics. So it's also an acute ventricular arrhythmia, but yeah, I'm not exactly sure why it's not seen. But. So which of the following drugs is most likely to be used as a first-line therapy for congestive heart failure? Okay. Yeah, so as I said, diuretics are usually good ones to give. Most patients with heart failure, the first line of drug is a diuretic. Yeah? Yeah, so first you do lifestyle changes, but this is which is the following drugs. Yeah. So the statins, there are multiple ones in this question that are right. Yeah, so it's just one. So if you could just give me a thumbs up maybe when you've kind of figured out the answer, and that way I'll show the answer and we'll go from there. Just because I have no idea how long it takes to do these. So yeah, they impair cholesterol synthesis in the liver, and that's through decreasing the action of HMG-CoA reductase. Sorry. It says oxidase. Yeah, so that seems like a really dog thing for them to do, but like faculty probably would. So yeah, just chuck a thumbs up when you kind of figured it out. Cool. Okay. Yeah, so our fibrates, as you can see here, they're good for triglyceride, whereas our statins are for cholesterol. Cool. So which of the following antiarrhythmic drugs is correctly matched with his mechanism of action? So atenolol is the right one. So lignocaine is not a potassium blocker. Yeah, basically it says the answers. Yeah. Everyone kind of clear on that? It's something you really need to sit down and just kind of. So the most likely drug to evoke an inotropic effect in a patient who has congestive heart failure is. Yeah. So mainly just know digoxin is inotropic. It's one of the big buzzwords. So Jessica's been getting attacks of angina pectoris when she climbs up the med building stairs. You decide to treat her with a sublingual nitroglycerin. While taking it, she might experience some side effects. And which ones would you? Good. Yeah. Yeah. So it's A. Yeah, pretty much covers. So the dizziness, you don't get increased blood pressure, you get hypotension because you're getting dilation. Again, hypotension. It increases your cardiac output and it causes tachycardia. Nitrates, as I mentioned before. Some more questions. So Joe presents with symptoms including decreased blood pressure, bradycardia, wheezing, with no apparent change in skeletal muscle tone. Which of the following drug classes would most likely cause this? Yeah, so it's a muscarinic receptor agonist. So Isabel is trying to improve her performance in viola solos and inappropriately takes a double dose of the non-selective beta adrenoreceptor antagonist, propranolol. Which of the following symptoms would she experience? Okay. So you would get bronchodilation. Think about flight and fight. Think about those sorts of things. When you get when you're in a stressful situation, you want to be able to breathe more, get more oxygen, and you want to have a faster heart rate. You want to have increased blood pressure and that kind of thing as well. So that's fine. It's an antagonist. Oh, yeah. That one is also incorrect, I'm sorry. Yeah, so an antagonist would reduce your sympathetic response. So you would end up with everything except for that. So would she not experience? I will fix that up as well. Sorry about So predominant adrenoreceptor in cardiac tissue is so I heard some beta ones. So the main clinical use of beta 2 adrenoreceptor agonists is for so beta 2 is your lungs breathing. You want to promote that, and if you have constriction, you want dilation. Cool. So a patient develops opioid dependence after being on a course of opioid receptor agonists. Which is the least likely cause? Yeah. So again, just going back to those drugs. Unfortunately, I can't memorize them for you. But yeah, these are just so you know, these are questions that are either very similar to ones that have been on exams or ones that are on past papers. So these are literally questions that they will ask you on an exam. So it's good to have a general idea of how they work. So which is the order of recovery for anesthetics? Oh, sorry. Good. So it's basically the reverse of induction. I don't believe so. Okay, you have a look. Okay, so which of the following is metabolized the fastest? Yeah, so B is an ester and it's metabolized in the plasma. So it's metabolized a lot faster than the amides. And the type of activation of new receptors blocks which type of channel? Anyone want to shout out an answer? Okay, I'm getting a lot of different letters. It's calcium. So you want increased potassium action because it hyperpolarizes the cell, and calcium prevents the release of a neurotransmitter. So by activating the new receptors, which is what opioids do, you reduce the calcium, which reduces neurotransmission, which reduces pain. Cool. So the following vasodilator drugs are likely to evoke a reflex tachycardia except. Okay. Does anyone happen to know the answer to this one? No? Okay. Yeah. Verapamil is cardioselective, so it vasodilates the ones on the heart only rather than around the body. But it is 3:30, and I know you've been here all day and this is your last lecture. So it's up to you. Do you want to keep going through questions or do you want to like wrap it up and you can have a look at the other ones in your own time? Okay, so thumbs up for keeping on going. Okay, cool. I'll just, yeah. Cool. So a patient presents with an acute attack of paroxysmal supraventricular tachycardia, which is unresponsive to vagal maneuvers. Which drug would you choose to terminate this attack? So this is a trickier one. Just note that it says unresponsive to vagal maneuvers. So you're looking at something like, I don't know, a reentrant supraventricular tachycardia, which I did mention on another slide. Oh my gosh. Yeah, so it's D. So it's specifically for the reentrant supraventricular tachycardias. It's a bit of a tricky question, but yeah, basically it's particularly good for the vagal unresponsive ones. Yeah, so this is a pretty easy one. Do you want to just shout it out? Yeah, so we're all done. So shout out to Andrew Kwai for his slides, which no worries, she used to guide the mine. I borrowed some questions from Ying Tong's questions. I'd recommend following the link. There are a lot more there than what I used. Thank you for Jess' help. You can find the mentioned drug doc there if you guys want silly ways to remember drugs which were on the glossary. But yeah, that's it. Feel free to message me.